So I'm going to talk again, like Joan said, about MicroPulse specifically for diabetic macular edema. We've been using MicroPulse in our practice for just about 2 years now, and so at the end I'm actually going to show a few cases from my practice, really in the clinical setting where I think MicroPulse shines. So these are financial disclosures. So let's talk about conventional laser first. Conventional laser, the photocoagulation is achieved because of protein denaturation when ocular chromophores absorb the radiant energy. Light is initially converted to heat in the RPE cell, which results in this gray-white burn, which is confirmation of the heat damage, where temperatures in the tissue can reach 20 to 30 degrees centigrade above baseline body temperature. And here's just an example of a recent PRP in a patient where you see those gray-white burns. In the treatment of DME, the theory, at least, is that originally was that microaneurysm closure, this direct closure of the microaneurysms, which was often fluorescein guided, is what leads to the macular edema resolution. But the reality is that the closure of microaneurysms is delayed. The closure rate is approximately 0.67% 2 weeks after laser, but 2 weeks post-laser, you can actually see a significant reduction in macular thickness clinically and can be quantified by OCT. So something else is definitely going on. You get, again, this early edema resolution. As far as adverse effects of conventional laser, we've all seen it. You can get retinal scarring, irreversible photoreceptor damage, and these scars can enlarge over time. When you do your initial treatment, you say everything looks good, I got these small little scars. Well, 5–10 years down the road, they can grow and they can get confluent, and these patients can get clinical scotomata as a result. The treatment endpoint with conventional laser is a visible high-intensity lesion like you saw in those pictures of the PRP, although typically with grid laser for the macula, you're going to be doing it at lower settings. This is a little schematic here. I hope you can see this laser pointer here. You got the laser, this bright white area in the center, that's the directly heated tissue, that's the destructive effect. That tissue is not going to be viable. And then but what you're seeing is the indirect, the effect of the indirectly heated tissue here around the central area where it was heated, and that's the tissue that remains viable and produces a stress response, which results in the anti-angiogenic factors being released and your resultant decrease in edema. So let's talk a little bit more about MicroPulse technology. MicroPulse chops your continuous wave emission into these spaced repetitive micropulses, hence the name, which allows for finer control of thermodynamic effects, a lower energy per pulse, and allows for tissue cooling between cycles. And I'm going to show you from some studies as well as just some case reports that you can get a very similar clinical benefit from MicroPulse as opposed to continuous wave laser without any tissue damage. This is an example here, we're going to talk about this in a minute, of different duty cycles. So the duty cycle was referring to the percentage of time that the laser is actually on in any given pulse. So this is again, go back for a second. At the top, that's your continuous wave. Duty cycle is 100%. So let's look at an example again. The pulse on time is the duration of each micropulse. The pulse off time is the interval between the micropulses. The entire period of time is you add those two together. The duty cycle is the percentage of on over the total time. So a very typical setting that we use, again, most of the time we use 5% duty cycles. So a very typical setting here, as you see at the bottom, you'll have the pulse on only for 0.1 milliseconds, the pulse off for 1.9, total of 2 milliseconds with a 5% duty cycle. So that's just to break down kind of how it's actually working. So again, let's talk about MicroPulse specifically for diabetic macular edema. And as I mentioned before, with MicroPulse laser treatment as opposed to conventional laser, the directly heated tissue in MicroPulse remains viable and able to produce that stress response, which induces the beneficial anti-angiogenic factors, many of which that you see here. And this is the study that looked at that. Again, this is sort of the important idea behind MicroPulse. You're not getting that direct tissue damage, you're just going to get that beneficial effect of the indirectly heated tissue that you see in conventional laser. So you may have heard of subthreshold laser. It's not the same thing as MicroPulse. Subthreshold laser is a continuous wave laser that's delivered in a subthreshold fashion using lower energy, but again, not the same thing as dividing the energy into micropulses. Micropulse divided laser energy will heat the tissue less than a continuous pulse, even if the total amount of energy is the same. And the reason is that when the energy is divided, into the micropulses, it allows for cooling between the cycles, which allows for little to no tissue damage. So this study here looked at spectral domain OCT imaging of retinal healing within 3 months post continuous wave, subthreshold continuous wave, and pattern scanning and micropulse laser treatments. And here you can see, hopefully you can see my pointer, in the continuous wave subthreshold laser. Immediately afterwards, you see this hyper-reflective band appear at the laser sites, which you don't see with the micropulse laser treated eyes. And the retinal morphology did not change at any time during the observation period after micropulse. Another larger study, this was a retrospective long-term review, comparing various duty cycles within micropulse. As I said, now we all use 5% duty cycles, and part of that is built on these studies here. The eyes treated with 10 to 15% duty cycles showed 8% incident of laser-induced retinal damage, but with the 5% duty cycle, none of the patients showed any damage, and that was using infrared, red-free, fundus autofluorescence, fluorescein, ICG, or spectral domain at OCT at 12 months. So 5% duty cycle is what we use. It allows for maximum tissue cooling between each micropulse, and this is why you can treat through the fovea. I'm going to show you some cases of that. So, and this is just going through a little bit more of the details about how you actually apply the micropulse laser. This is just a cartoon or drawing here of continuous wave laser, again showing this large area where the retina is damaged, and then you have this viable tissue along the outside. Now with micropulse, you're using a low intensity laser, and so in order to get a clinical effect, what I'm going to show you in the next study is that they found you need to do a high density of application over the area of diseased retina. So what you want is this sort of confluent treatment over the entire area, otherwise you're not going to see a big effect. And so that's what you want to see. So this trial here was a prospective, double-masked, randomized controlled trial, minimum of 1 year follow-up, consisting of 123 patients with previously untreated diabetic macular edema, visual acuity between 2040 and 2400. The study arms were randomized to modified ETDRS laser photocoagulation, low-density micropulse laser, and high-density micropulse laser. And this is the sort of summing up the results here. You're going to see the biggest effect here with your high-density micropulse laser. You get a significant decrease in the central macular thickness and the largest increase in best-corrected visual acuity. So they'll tell you about it here, but they have a Texcell pattern scanning system that you can get with the micropulse, which really makes it very easy to treat in a confluent, high-density way. Gives you these nice grids. This is, again, that tight spacing is really what's shown the best clinical effect. So it's helpful. You don't absolutely need it. You can apply it without it, but it certainly makes it easier and more consistent results, I believe, with that. And it also with this laser, you can also do continuous wave laser, so the pattern scanning really can make PRP very easy as well. So I'm just going to go through a couple of cases here. These are my patients that I've treated. So this first one's an 80-year-old gentleman with type 2 diabetes, past history, mild NPDR. He's really a monocular patient. His right eye had advanced glaucomas, poor vision. His A1C, as you'll see with a lot of my patients where I am, it's unknown. They don't know what their A1C is. They don't check their sugar. And his history is he's had some mild vision loss in his good eye. So he has noticed a vision change over the last couple months. Here's his fundus photo and his fluorescein. You can see just mild NPDR, just a few little microaneurysms very close to the fovea. And here's his OCT. I'm sorry that this didn't come through as clearly as I would have liked, but you can go with just the colors here and see that he does have central thickening. His vision was 20/30 -2. So what are the options here? You can observe it. You can use anti-VEGF. You could consider a steroid. Continuous wave laser, although this is really center involving edema. In this day and age, continuous wave laser for this is definitely not the right approach. Or micropulse. So, any of these options are, as far as observation, anti-VEGF, or steroid are reasonable, but whenever I'm going to do an intervention on someone, I was trained at Wills, and we're very, believe it or not, very conservative. I was always trained to think about, if the worst case thing happened, can I look back? Do I feel good about what I just did? He's a monocular patient. His vision's not that bad, but he's certainly symptomatic. He's certainly having vision changes. And if I give them an anti-VEGF, fortunately, the incidence of endophthalmitis is rare, but it happens, and I see it. A little biased because of I'm a retina specialist, so we see the endophthalmitis cases. But I was happy to have another option to give him. So I did one treatment here in September, and you can see 3 months later he's starting to see an effect. And it's not uncommon with MicroPulse. You got to counsel these patients that they may need more than one treatment to get you to your endpoint. Another treatment a few months later, so now he's 20/25 plus 1. His thickening, his edema is better, and he's happy. Didn't have to give him any injections. Another patient, 73-year-old woman, moderate NPDR, doesn't check her glucose, so she's completely asymptomatic. She had no idea anything was going on. Her doctor told her she had swelling. Here's her fundus photo and her angiogram. Now she came in, she was 20/40, she had this nasal edema. This is not center involving, but it's pretty close to the fovea. And actually, she was completely asymptomatic, sorry, happy with her vision. So I didn't do anything, I just watched her first. I said, let's just see where this goes, try to get your sugar a little bit better. She came in a month later, the edema is getting worse, her vision's starting to get a little worse. So I decided to treat her, just one treatment with MicroPulse, and 3 months later, the edema is pretty much gone, her vision's up to 20/30. So she was happy. Another 80-year-old gentleman, not the same one, mild NPDR, A1C of 8.1. He's had some mild distortion in the left eye for about 2 months. His left eye is 20/30 -1. And here's his, again, just a small little patch of edema right adjacent to the fovea. You could certainly do any of those options we talked about first. You could watch it, you could treat it with anti-VEGF, but one treatment with MicroPulse 4 months later, and the edema is almost completely gone. Vision's better. He was happy. I was happy. Next case, 67-year-old gentleman, history of PDR. His right eye, again, he's a monocular patient, end-stage tractional detachment in the right eye, and he has had previous continuous wave grid laser. He's 2100, A1C of 7.6. You can see he's had PRP. He's got old grid laser here, and he's got this edema here. Now, there's no question that this edema right now is not affecting his vision. He's got some foveal atrophy here, but he's 2100. This is his better eye. You could wait and watch it and see if it's going to get worse. You may, at that point, you're not going to really be able to do much more grid laser. He's already had a lot of old scarring here, so you're not necessarily going to add more of that. So, treated him with one session of MicroPulse. A few months later, the edema is gone. I don't have to sit there and worry about it, come back again in another month, 2 months, is just getting worse. I might have to do injections. This one treatment and the edema was gone. So I have many more patients like this, but I picked 4 just kind of for different types of patients, some with previous laser treatment. But again, where I think MicroPulse has really aided my practice is in those patients where you don't want to give them an injection for whatever reason. The patient doesn't want an injection, they had a complication in their other eye, they're monocular, whatever reason you want, they don't want to do an injection, they have center involving edema. Conventional wave laser is really not a good option. You have another option for these patients. And it certainly works well for even extrafoveal edema, just without giving them those big scars, 5 or 10 years down the road. So, thank you.
Thank you very much. Are there any questions? Okay, you can patiently pass this over to you. Okay.
Which wavelength laser are you using?
We're using the 532.
Does it change at all depending on the wavelength laser in terms of the type of treatments you do, retina-wise?
Not really.
Yes.
Is it fair to say that you think that the indications for treatment would match those from the ETDRS?
So
you're treating those parafoveal swelling even though they're not center involved?
Yes. So you certainly can.
In my practice, if they have center involved edema and their acuity is dropping, they're a lot more likely to say, okay, give me a shot, because they see that they're sinking. But patients like that don't want it. Patients who have 20/40 and no center, they don't want injections.
They don't want anything done.
And I don't want to watch it.
Right. So you can. The bottom line is you can use this for any of those situations. You can use it instead of your conventional. I mean, I don't really do conventional wave grid laser anymore. So you can do MicroPulse even if it's not in the fovea. It just gives you another option for some of those patients. I mean, if you're in retina, I mean, you'll see patients who come in who are 20, 25, they're symptomatic, they have center involving edema. If it's small like that, I'm personally just not that excited about giving them an injection. Sometimes they're asymptomatic, they don't even realize that it's going on, and you're like, well, I could wait for this to get worse and then have to start injecting you. Why not just treat it now and save them that, and save you that trouble down the road.
Thank you.
Do you do much combination treatment with anti-VEGF agents plus MicroPulse?
Yeah, so that's definitely a good question. I definitely have. There's no question. You're giving patients anti-VEGF. Usually my first, it really just depends on it's very patient specific. Usually my first step, if they're already getting injections, is I'll often switch to Ozurdex or add Ozurdex in. But you have a whole bunch of patients who you can't give Ozurdex to for a number of reasons, whether it's IOP issues or aphakia or ACIOL or whatever it is, that you can then add this into. You can add it into anti-VEGF also. You can do any sort of combination you want.
We have another question over here.
In terms of settings, can you comment on spot size, I guess the density, how close the spots are,
Sure.
the power?
So it's sort of an evolving thing, actually, the way that the settings have gone. Typically, you'll use the conventional wave laser first to get your power settings. As you know, when you've done, anyone who's done conventional wave laser knows that for any patient, the settings could be completely different. One person, a power of 50, you're going to get a bright white spot. Another one, you need 120 and you're not going to get anything. So you start with conventional wave laser, usually a duration of 100 milliseconds, get your power up to where you're seeing that effect. Switch over to 200 spot size, 200 millisecond, 5% duty cycle, and multiply the number that you got that effect at by 4. When I first started doing MicroPulse, the recommendation was to multiply it by 2, and it's gone up because we're seeing you need a little, it's safe to do the higher power, and you're going to get a better effect. And then you really want the spots to be confluent. So if you're going to do the pattern scanning, you just set it to the tightest grid for you, and it'll do it right for you. If you're not, you just have to try your best to paint kind of over that area. You don't see it, so you got to watch what you're doing.
Question over here.
Hi, this is a follow-up to the frequency question. So before you used 532, the green light MicroPulse, what were you using before? And then how did you choose the 532 wavelength versus 577?
Sure. We were using a Zeiss green laser before. Basically picked it because of price. Price with you can look at, I think there's a lot of studies showing that you can have somewhat similar effects between the yellow and the green. There's some reasons that one may be more advantageous than the other. We've been using green laser before. We just chose the green, and it's worked well.
We found it's a preference, but you get comparable results with both.
Thank you. When is a patient not a candidate for MicroPulse?
So I think in cases where you have significant retinal edema, it's very similar to conventional grid laser. If you have real significant thickening, 500, 600 microns, even with conventional grid laser, you're not going to get a great effect. So I think you have the same limitations here.
So is that a case where you would use it in combination with anti-VEGF?
Either a combination
therapy?
with anti-VEGF or Ozurdex.
Okay.
Yeah.
Thank you.
Any other questions, comments?
In that setting, sometimes what we'll do is we'll do anti-VEGF or Ozurdex to get the edema down. Correct. Then once it's down to the level where you think you can then treat it with MicroPulse effectively, you add the laser in to try to get them off the injections. It's variable. I think in some cases yes, in other cases no. I think it often depends on the eye. It's certainly it's what I usually do to try when we get to that point. To try to get them off. I mean, most of the time with DME, if you look at the studies, the stuff comes back with anti-VEGF. So trying to add something to give you a longer effect without having to get back on the injections is helpful.
Great, thank you.
So Adam, this is great essentially. If you've got a fat, juicy, leaking microaneurysm in your FA, how do you handle that with MicroPulse?
So, if you have a big, juicy, leaking aneurysm, a microaneurysm that's far away from the foveal center, I think either option is going to be fine. It's going to work with MicroPulse.
MicroPulse does work.
MicroPulse will work, but it's going to take more than one treatment. If you have a lot of edema there, it will. And I didn't show an example of that, but I do see patients like that. But if you're talking an aneurysm that's very far from the foveal center, and you're really just applying it right to that aneurysm, right in that area, it's a focal area of leakage, you can just do continuous wave either one will work
Thanks.
fine.
Thank you very much. And you'll be here for a few minutes.
Yeah.
If there are any other questions, you're welcome to come up and talk to Dr. Kirstenblatt. Thank you very much.